Good morning. This is Dana Parsons with LeadingAge Virginia, and I just want to welcome everyone to our coronavirus weekly member update. We know you all are very busy, so thank you so much for taking out the time to be on the call with us this morning. We would like to begin with a topic related to testing for coronavirus in all nursing homes. So I'd ask if Dr. Furlano is available, or Christine Gray to speak to that issue, or Kristen Collins.
Christy Gray is here. I'm not sure if I haven't heard Dr. Fulano or Kristen.
Okay, well, would you like for us to wait, or did you want to go ahead and begin talking about that topic?
No, that's fine. I can definitely begin talking. And I'm sorry, I was kind of waiting for everybody to come in. Is it just about PPS and point prevalence survey testing in long-term care facilities?
This is regarding the email exchange that we had this morning.
Thank you. Okay. I'm just going to pull it up, make sure I'm touching specifically on the question.
Okay. Dr. Fulano is running a few minutes late, but she says she'll be joining us. And specifically, we had asked if you know of any partnerships between private facilities and testing capabilities to offer testing to our residents through local health departments, a hospital, a private lab, and so forth.
Thank you for the reminder. I was having issues finding it in my email. My name is Christy Gray, and I'm helping with Kristen Collins to oversee the testing activities in Virginia related to COVID-19. We help to coordinate from the local health department perspective. We help to coordinate testing within long-term care facilities. That includes the testing kit, the actual specimen collection, the arrangement with the labs to drop off the testing kit, have the lab run the testing, and then get the results back. And all coordination with the local health department to have discussions and relevant decisions after the results are back. So that's available through the local health department. I think the arrangements with health systems are specific to the health system. When we are talking with long-term care facilities about doing testing in the facility, we always do recommend that you connect with your healthcare system in your area so that they're aware, as well as in case you might need some support after the testing is done. It is good to keep them aware of what you are doing. We also recommend that you follow up with the MRC in your area to check on their readiness in case you might need to call on them. Relating to specific labs, the health department has contracts in place with certain labs to do our coordinated point prevalence survey testing in long-term care facilities. That doesn't mean that you can't contact a private lab and do your own if you already have relationships with labs that you do for other services. You can reach out to them and see if that's something that they offer. And I really recommend you contact your local health department, have a close working relationship with them, and about how you might want to go about testing your residents and staff as it relates to COVID-19. I'm happy to provide any clarification or if there are additional questions.
Yes, if you could please enter your questions in the chat box. And are you able to stay on with us for the remainder of the call as other questions might arise and Dr. Furlano joins us. I'm not sure if she's been able to get on.
Yes, I can stay on for the call.
Okay, great.
I think one question that we've heard is, and I'm sorry if you mentioned this, Christine, and I missed it, is who's paying for all the testing now that they're making, it's going to be mandatory to test all nursing home residents?
Hey, this is Sarah Lineberger, also at VDH, and Christy, feel free to answer, but that's a really big picture question, and obviously the CMS directive just came out a day or two ago, so we're trying to pull together agency leadership to talk about the funding question.
That's
Thanks,
great.
Sarah.
Thank you.
Yeah, this is Christy. I would echo that it just came out, and we are trying to determine that. If you are doing coordinated testing with VDH, you contacted VDH, you would like us to help coordinate it, the testing costs are covered. And if you're doing it privately with the lab, the health department is not currently involved right now as it currently stands. We're not involved in that. So you would want to consider any kind of billing that would be included in that. The same thing with a health system that you might contract with to come in and do testing and do the testing in their lab. After leadership reviews this CMS order, then we don't have a decision yet about how that might change things.
Great, thank you. And a follow-up question was, do you have any idea, and you might not at this point, what the expected timeline is to complete the testing of all nursing home residents?
So these are skilled nursing facilities, which are about like 280. Is that that?
Yes.
Okay. It depends on. Right now we have about 54 on our list that we want to contact to determine if a PPS is still warranted. If they're still interested, maybe they've done one already by the time we've gotten to them. There is about 180 others that we may have already. We have started with a list of which we knew that it would be a good idea to maybe to initiate and ask if a PPS is still warranted, either by the facility with the local health department, and a joint discussion of, does this still make sense based off of, have you gotten already one, have you not had any more cases? There's lots of different variables to consider. And then there have also been, as we've been working on that, other skilled nursing facilities that have requested that a PPS be done, and those have been added to the request list and have had those done. So if you are interested, if a long-term skilled nursing facility is interested in getting one done, please contact your local health department so that we can get it scheduled. I'm going to keep hammering that. We need to hear from you that you want to get it done. If we find out that you have cases and we're looking into an outbreak, then we will definitely initiate that first because we're aware of it. But if you're interested and have not been contacted yet, please contact us so we can get it scheduled.
And this is Dana Parsons. I just want to clarify that when we're talking about testing, we're talking about just for the nursing homes. We are not talking about assisted living and other levels of care. Is that
there are instances in which it would be warranted if there is an outbreak in those facilities.
But in terms of the new guidance around testing all residents, that's only about nursing homes if there's no outbreak, correct?
Sarah,
This is Sarah. Yeah, this is Sarah Lineberger. I mean, that's correct that the skilled nursing facilities are the ones, obviously, that fall under CMS. I did reach out to the Department of Social Services this morning to ask how, they have been using CMS guidance for assisted living facilities throughout the coronavirus response. And so they're sort of thinking through how DSS will interpret and provide guidance to the assisted living facilities. So I think more to come on that. I don't know that it would necessarily be required testing or anything like that, but DSS is working through that.
Do we have any more questions? Go ahead, I'm sorry.
As Christy mentioned, and as you all know, I mean, we have been doing point prevalence surveys in assisted living facilities already when they have an outbreak or if they've requested that.
Okay. Do we have any more questions in the chat box, Melissa?
No, there definitely still is some concern that some of the local health departments, Sarah, are actively indicating that they are overwhelmed. So I think that some members are feeling that, that pain for them, and just wondering how they're going to handle the increase in testing response. And then the second contact is how do you want the contact made for PPS?
So the VDH has what we call a form, a red cap form, which is a platform to do different surveys and such on. And our local health departments have access to that form to submit a request for a PPS for a facility. I do recognize that the local health departments are definitely stretched thin with COVID-19, and we are actively working to hire more staff to assist with that. So the way to go about it is to contact your local health department and request a PPS, and they'll talk through with you the number of things that we want to make sure that you're considering as it relates to a PPS, such as, have you talked to your health system? Have you reached out to MRC? Are you just making sure you're considering everything that's involved? And we'll ask for information such as the number of residents, number of staff, if there's a preferred date or time to conduct it, how much assistance do you need to conduct it? Do you just need the kits? Do you need some specimen collection personnel, etc.? So they will go through a number of questions and discuss with you about conducting one, and then they would put the request in which we would, the central office VDH team would then look at your request compared to the lab capacity and the personnel that we have available to schedule it.
Okay, there's a couple more questions that have come in. A clarification. So did I understand that if we do a point prevalence survey through the local health department, there is no cost to either staff or residents?
That is correct.
And then—
Hey, Dana, can you hear me? This is Lori Forlano.
Yeah, we can hear you.
Hi, sorry about that. I was having some issues with the audio. When there's a moment, I had a few things to say.
The moment now. Go ahead, Dr. Forlano.
Okay.
Yeah, please go ahead. Thank you for joining us.
Yeah,
we know how busy you are.
I was on, but I couldn't, for the life of me, unmute myself, so I had to hang up and dial back in. Thanks to Christy and Sarah for handling all the questions. I think, if this is redundant, I apologize, but I'll try to be concise. I think our priority is to support as many long-term care facilities as we can in conducting what we're all calling a point prevalence survey and testing all residents and staff, that one point in time. Obviously, that doesn't happen overnight. So LeadingAge's approach has been to prioritize roughly about 100 facilities, and I'm sure Christy talked about it, but we've done that based on case data, acuity, et cetera, and other variables, types of settings. Long-term care facilities are not the only facilities that are served with point prevalence surveys. We also serve correctional sites, sometimes workplaces. We're also managing community testing, things like poultry plant outbreaks, et cetera. We do consider requests for facilities that have no cases, et cetera. So that's been the process to date, and we're continually working with our local health departments to ensure that they understand this approach. I think in the last, say, 5 days or so, we've recognized the need for some more communication to all stakeholders, including our local health departments. The CMS recommendations that went out last night obviously are a whole new animal here. So our goal is to try to support that initial point prevalence survey. And you certainly don't need to wait for us if you can conduct one of those on your own. I will say in general, I think the expectation moving forward will be that for ongoing routine testing and the capacity to do testing, will need to primarily be the responsibility of the facilities, and public health will be there to support an outbreak response and our continued point prevalence survey project throughout. So we want to work in partnership with you and to get to a point where we're not all reliant on the National Guard, et cetera. So right now, while these testing events are not charged to the patient or the facility, we would like to explore third-party billing as part of routine testing. That makes sense to use the payer that exists, but we haven't worked out that detail yet. So I think moving forward, we're going to contemplate different parts of the model, understanding that this is a crisis point right now, and we absolutely want to support and help. I hope that's helpful.
That is helpful. Thank you. There's a couple of questions that have come in. So from a VDH perspective, would it be wise to also test for the COVID-19 antibodies? Would be interested in knowing COVID-19 infections that are asymptomatic.
I can try to handle that. So I think the short answer is that we're still learning more about the role of antibody testing, and time will tell what role antibody testing will play in, say, return to work or presence of immune response. A positive result on an antibody test obviously indicates that a person has been exposed to the virus at some point in time. A negative result could indicate that you haven't been exposed. It could just be that antibodies have not yet developed. The antibody levels might be too low, or your particular immune system may not have mounted a response even in the context of exposure. A positive antibody test does not diagnose acute infection, obviously. A false positive result is still possible. So it's just, and a very key point about antibody testing right now and our knowledge about it is that it's not known right now if a positive serologic result means that a person is protected against reinfection. And we also don't know what the strength or duration of any protection that might exist. So I think the science is still being gathered on that, and we hope for more information soon. And we will be actively watching for that information.
Thank you. A follow-up, or not a follow-up, another question, Dr. Furlano, is it would be helpful to address the subject of testing and the testing mandate in the context of CCRC, which has multiple levels of care, multiple regulators, and staff that crosses level of care. So have discussions started on the impact of multiple levels of care settings?
You're going to have to help me out with those acronyms.
Yeah, sorry. So retirement communities that have nursing home, assisted living, and independent living. And so they're regulated by different agencies, and they often have staff that cross all levels.
I think that's an important point, and I think it's probably one that VDH needs more time to think through.
And we'll be happy to, since we represent the CCCs, we'd be happy to talk that through with you.
This is Sarah Leinberger. I mean, typically in an outbreak response in one of those facilities, we would address, any portion of the facility where there's been transmission. So that would sort of be looked at as a whole picture, but certainly, the different licensing requirements come into play. But we're pretty used to, in other outbreak situations, working in those types of facilities and considering the parts of the facility where transmission has happened.
Thanks, Sarah. Another question is, what's the outlook for the availability of tests as communities need to keep ramping up?
Yeah, that's a great question. I don't know if Dr. Remley is on. I think I saw her name.
I actually see her name when you talk, Dr. Fulano.
Dr. Remley, if you're on, just hit on the phone, hit *6 to unmute yourself.
Maybe oh yeah, she and I must be using the same link, or okay. What I'll say is
that happened.
I don't know.
That happened to me. I was going to sign in as Dr. Remley, and I was able to change it.
The short answer to that question is first of all, it's a great question. VDH and the Unified Command at the Commonwealth level are all working very hard to continually increase testing capacity. So I think the outlook is that it is increasing with time. However, that's in the context of lots of increasing demands, appropriate demands for increased testing capacity. So it's increasing with time. And we hope it will get better.
Yeah. And then another question came in. If a community chooses to handle the baseline testing of residents and staff in-house, what is the time frame in which all testing must occur? In other words, once the testing starts, what is the time frame it must be completed, i.e. 48 or 72 hours? With the testing representing a point in time, need to understand the time frame this testing is expected to be completed once started. Sorry, that was a long question.
I'm not
sure.
This is
Sarah. And
yeah, go ahead, Sarah.
And Christy can chime in, but I mean, typically, ideally, you would test everyone in the same day, and that includes residents and staff. We understand that it can be difficult to get all staff there on the same day. So sometimes this, a single testing event might happen over 2 or 3 days, but ideally you test everybody at the same time. Does that answer the question?
I think so. And just a case in point, my husband's community in Maryland, they did National Guard testing over 2 days. They had 600 people that needed to be tested. So it was all day Monday, all day Tuesday. I know that's not Virginia, but just an example of a large provider that had to get a lot of people tested.
And this is Christy, and we have had to do that is over 2 days. Sometimes it's usually more in the correctional facilities. We have to do that because they are in more of the thousands, but it is possible we might need to do it over 2 days.
Okay, so this is going to be, this is a medical question, and I'm not a nurse or a doc, but I'm going to try and get through it. Quiddle makes a nucleoprotein antigen testing, which is not as accurate as PCR, but quicker, and some facilities already have the Sophia software that we used for influenza testing. Should we not go this route?
This is Laurie, and I am not sure I am equipped to answer that. So I think I would have to consult with our laboratory partners and get back. Dana, if you wouldn't mind sending that question to us afterwards.
Sure, absolutely.
Thanks.
I'm going to send it to you right now, actually.
I got 2 more questions that have come in. So with independent living, assisted living, can they request through their local health department for testing of other residents, staff with a positive case, of course, with notification of DSS? Routine testing with different levels of care. Sarah, I think you just spoke to that.
Yeah, so we have been testing in assisted living when there are cases or an outbreak. And I'm not sure we've done any independent living, but certainly you can request that and we can sort of put that in the queue.
And if staff refuses to be tested, what is the ramification to that, to them personally and to the facility?
This is Sarah. I can start. I think, to this point, we've just been recommending that in order to address the problem as a whole, certainly staff should be tested at the same time as residents, but I'm not sure. I would need to talk to OLC a little bit more to understand if there would be licensing, if licensing has more teeth potentially for that question. Now with this new CMS memo, I think that's a really good question, and I don't think that I have a good answer right now. So let me talk to OLC and we can loop back with you on that.
I think all of us need some time to kind of digest the CMS document. I think some of the phrasing I saw in there was that the facility needs to have a plan as to what they will do with staff that aren't tested, and frankly, even patients, and how, for example, if a patient refused testing and they're in a wing with other COVID cases, will they treat them as a positive case? Assume that kind of planning.
Well, Dr. Furlano, this is Melissa again. Thank you so much. We know how busy you are, and this was really helpful. There aren't any more questions right now in the chat box. So just thank you, and we know you have other things to get to. We really appreciate everything you're doing on our behalf.
Thank you so much. And please let us know. I know, Melissa, we've been talking about this a lot. Please, we're definitely interested in feedback on barriers to testing and how we can help overcome those barriers. And I think when I say that, not only with the point prevalence survey, but ongoing routine testing needs, especially in the context of these new CMS recommendations. So thanks for the time today.
Thank you. Dana, back to you.
Yeah, I just want to thank you all so much again for being on. We're going to switch gears for a little bit, but I'm sure we're going to be getting back to some of these topics as we talk with Sarah and Kelly a little bit later. But we're really excited to talk with you today about the opportunity for nursing homes to apply for communicative technology with Cmp funds. So we are very delighted to have Terry Smith, the Director of the Division of Aging with the Department of Medical Assistant Services, to just provide us with a brief overview. Also in our update today, the template that you will need to complete to apply for these funds will be in our update this afternoon. So over to you, Terry.
Thank you so much, Dana. Can you hear me?
Yes, we
Hello?
can hear you.
Okay, wonderful. Let me begin just with a really quick overview of what I think we already know, which is that the Cmp Fund is a collection of penalties that CMS imposes against skilled nursing facilities or nursing facilities, either for the number of days or for each instance a facility is not in substantial compliance. We have had this fund for many, many years. 2 years ago, CMS requested that we set up all states, not just us, set up a formalized CMP process, and we do that through an annual request for applications. So that's the way that was developed. Obviously, VDH does the surveys. That's Department of Health performs the surveys. CMS can set the fines, and DMAS, keeping arm's length from the VDH surveyors, collects the funding and now has a formal process for distributing that funding. So that's what's different in the last couple of years. Moving quickly from that, because of the COVID-19 this year, CMS released guidance for communicative technology, and they're very interested in getting this in the hands of individuals in nursing facilities. What they said with this is that CMP funds for other purposes other than communicative technology could be temporarily suspended. So DMAS has made that decision to suspend what was our regular cycle of funding and to issue funding for communicative technology. And we have put that out in a Medicaid bulletin, and that is posted on our website so that individuals can see that our typical process has been postponed. Last night or yesterday afternoon, we also put this application on our webpage. But I think it's great that Dana is putting it out as well. CMS did develop the application template for requests for communicative technology. It is a relatively short form with check boxes, and it permits a nursing facility to request funding for tablets and accessories, including headphones and tablet protectors. I'll go a little bit more into detail about that. And this is intended specifically for use by residents of nursing facilities for communication with families or telehealth visits. This was first made available in April from CMS, and we are now putting it out. And I will tell you that this form is intended to expedite the dispersal of funds, and we are on an exceedingly tight time frame for that. What you need to know is that a facility can ask for up to $3,000, and if they ask for $3,000 or less per facility, then that will be approved very quickly by DMAS. If the request goes over $3,000 per facility, then it needs to go back to CMS for approval, which is the way our normal process works. That may slow it down a bit, but people are free to request more than $3,000 per facility. The devices that are purchased should be shared amongst residents with a ratio of 1 device to 7 to 10 residents, and that is a CMS request. Let's see, the allowable devices, and I'll just whip through these, are iPads, Amazon Echo Show, Kindle Fire, Samsung Galaxy tablet. We have accessories like protective covers, headphones, those types of things that are approvable. And the prohibited expenses are travel, software subscriptions, admin fees, or indirect costs. And I think you know what those are. So we have put out that template. We really are pushing to have this template back by the 27th, which is 1 week from when it was issued. And I know how incredibly fast that time frame is, but we are dedicating staff to move through this quickly. While we have not advertised this or solicited until yesterday, we already have close to 50 applications from facilities that may have operated in other states and knew that this would be coming out in Virginia at some point in time. So those that we have already received, we are going to process as well. And anything that we receive between now and the 27th, we will process as quickly as we can. And thankfully for Dana, who's willing to push this out, that helps us tremendously because we do want to get these funds out there, and we could use all the help we can do with this. I will give you just a real quick, I've got this somewhere, if you want to include this, we have dedicated one staff person. You can also send it to the mailbox at DMAS, but the staff person that can accept these is Courtney Richter. It's COURTNEY.RICHTER@dmas.virginia.gov. And that will be a fast point of entry, and then we can get it to the individuals that are quickly reviewing this. If we have questions and you go over $3,000, we will call you and ask if you would like to reconsider. If you don't, then we will prepare those applications for CMS. And that is it in a nutshell. And I do apologize. We've worked as quickly as we could. We had some approvals from CMS to obtain before we could move forward with this. But we really encourage you all, if you can use this technology, if the families, if your residents, if the staff can use this technology to assist individuals to connect with their loved ones during this crisis, then we will have done a good job with this. Did anybody have any questions?
There are a few, Terry. Thank you so much for that, like, incredible overview. And I've put Courtney's email address in the chat box, so you will.
She'll love it. She'll love it.
Oh, I just did too, Melissa. Sorry. We were.
It's all good.
And you, Dana, this time around, just want you to know. So, Terry, one question that came in, is this available for all nursing homes, including non-certified facilities?
We are going to also we are trying to push out something that is, I know that we will do anyone that is certified for Medicaid or Medicare. And that is about the best I can do on a response to that. So they can be duly certified or certified one way or the other.
And are any of these funds available to help with the Wi-Fi infrastructure to support the iPads?
Well, that's very interesting. We hadn't been asked that question. Wi-Fi structure. If you could just shoot that one to me, I'll take it back to Courtney and I'll get something back to Dana as quickly as I can on that.
Great. Dana, will you take care of that one?
I will. Absolutely.
Thank you.
Thank you so much, Terry.
Yeah, thank you, Terry. We really appreciate this info.
Sure. We'd like to come back sometime and give you a larger overview when this is over of what we can do with the funding now and some of the uses.
Absolutely. That sounds great.
All right. Thanks so much.
Thanks so much. Okay. Well, now we're going to move on to the Virginia Hospital and Healthcare Association update. So over to you, Kelly.
Thank you. Good morning, Dana. Can you hear me?
Yes.
Good morning, everyone. I'll just provide a couple of updates in terms of what we are working on, not only with the associations, but with the state and with our healthcare coalition. So a couple of weeks ago, I think we had discussed the contracted work, bringing in a consulting firm, Russell Phillips and Associates, and their team to help us with some operational plans. And about a week and a half ago, we held regional calls with our long-term care and hospital partners to discuss what some of the needs are from our long-term care facilities across the state, as well as where our hospitals could potentially provide support. Following up on those discussions, there were really some large bucket issues that were identified consistently across the state, and it was the need for continued guidance and training on isolation and quarantine, on fit testing, on proper donning and doffing of PPE, on PPE conservation and reuse techniques. In addition to that, we have had additional follow-up conversations with many of our partners and understand that there are some long-term care facilities that are willing to accept COVID-19 positive residents. There are some who don't necessarily have the resources to do that right now, and some who might even consider becoming a COVID-only facility if we were to get to that level of planning. So our Russell Phillips and Associates partners have developed kind of just some questions that we're going to be looking at in terms of how we can get a better understanding of what each specific facility's capabilities are. And this relates to the willingness and ability to accept COVID positive patients, as well as what specific training needs are needed within each individual facility. And so we've been working on those questions. We've been working with our healthcare coalitions to determine, a lot of them know some of those answers by working with you all directly already, and then determine what the best way to move forward with that, with obtaining answers to those questions will be. The second piece that has come out of this and more rapidly is relating to the conversation that was had earlier on this call and the point prevalence surveys that are being conducted. And we've been working with our partners at the associations to determine kind of what the implications of those are, but also we'll be working with VDH, we've got a call after this, with Sarah and her team, to discuss what some of the implications of those surveys are, but also what some of the lessons learned are, and what are the considerations that should be taken into what should be taken into consideration if you're going to have a point prevalence survey. In addition to that, we have a lot of our hospital systems that have provided assistance post one of those surveys, and so we've got some great lessons learned and things to consider from the hospital perspective and from the long-term care facility perspective that are based on the outcomes of those surveys. And so what we're going to have Russell Phillips do is really just start to put together guidance documents, which is just kind of a coalition of all of the considerations that should be taken into place based on, the conducting of a PPS, in addition to what some of the impacts of results of that could be. And I did hear a lot of what we had discussed were some of the same questions that you all had this morning. So we're going to be working with VDH and with the associations on developing some of those guidance documents, as well as we are working with some of the facilities that have already had those surveys conducted to really hear what their experience was and what insight they could provide that we could share with the rest of you. So that's an update on the Russell Phillips and Associates project, more continuing to be developed as our work with them continues to expand. The other thing I would want to mention is PPE. We are continuing, obviously, to work with the state, VDH, and VDEM on distribution of PPE to long-term care facilities. We do know that this is still a significant challenge with all of your facilities, and it has been significantly challenging to get distributions from the state to our healthcare coalitions. We do not have a lot of supplies in the healthcare coalitions right now. We have a lot of outstanding requests from the facilities that need to be fulfilled, and all of our coalitions have outstanding requests that still need to be fulfilled to the state. And we've experienced some significant delays and challenges. So we're continuing to work with the Virginia Department of Emergency Management and the Virginia Department of Health to get the state cache of supplies out of the state warehouse and into our coalition warehouses so that they can distribute to your facilities. And we're also working on how we can better coordinate, you know, post a PPS survey, understanding that that may change the operations of a facility, how we could prioritize those facilities for PPE if we know ahead of time when those are going to be conducted. So that's a big challenge right now. One of our coalitions, for example, has not received any of the distributions from the state based on requests that they've placed a couple of weeks ago. So while they are continuing to work with you all on the VHOS reports and on the new PPE request process, just know that we're still having some significant challenges actually obtaining supplies from our partners, and we are continuing on a daily basis to work through some of those challenges, as well as to improve the process for requesting and obtaining supplies from the state warehouse. We have a couple of calls scheduled this week as well as next week with our state partners to really identify if we could pre-deploy potentially PPE as opposed to being reactive with the burn rates, and et cetera. And hopefully, we hope we can make some headway in ensuring that process is a little bit more coordinated for things to end faster in the future. Dana, I believe that's all. I'd be happy to answer any questions.
Yes, we do have a question. If OLC also wants to chime in, the question is, what is CMS's and VDH's opinion on having resident activities outside if the residents are at least 6 feet apart and everyone's wearing masks?
I don't know if Sarah's on the line. I'll be able to answer that.
This is Sarah, and I believe Kim Beasley, who's the Deputy Director of the Office of Licensure and Certification, was able to join. So I don't know, and I was going to see if she wanted an opportunity to just talk to some of the other questions that were asked earlier as well. Kim, are you on the line?
I saw Kim was on. Kim, you'll need to unmute yourself if you're still on, or if you've called in, use *6.
In terms of the question about activities outside, I mean, certainly we really understand you know, that there are a lot of other implications for keeping residents in their rooms, psychosocial, etc. And so I think any way you can creatively figure out how to have residents out of their room and getting exercise safely, like you talked about, wearing masks, being 6 feet apart, I think that makes a lot of sense practically. And so I would encourage you to think creatively about how to accomplish that.
Sarah, another question has come in, and I'm not sure if you're the right person, but I always start with you. Are we now required to test all of our residents and staff, even though we currently do not have a lab-drawn positive test?
I think that's a good question, and I think we're working through the details of the May 18th CMS memo and really what implications there are for facilities in Virginia. So I think more to come over the next couple of days. I mean, up to this point, we've been prioritizing point prevalence surveys for facilities that have had cases, and we're playing catch up just to accomplish that. I know somebody asked about, you know, when everyone should have baseline testing done, and you know, there have been some reports that that should all happen in a 2-week time frame, but that's really not very realistic with the resources we have. And so I think we're still prioritizing, at least, you know, in the short term, facilities that still have cases, and that we're having conversations the rest of this week with our leadership about how to accomplish what CMS is laying out for baseline testing for all facilities, including those who don't have cases. So I think more to come.
Great, thank you.
This is Kim Beasley. Are you able to hear me now?
Oh, yes, Kim, we can. Thank you. Thanks for joining us.
Oh, great. I was on the phone, then went to the computer, then went back to the phone. So finally.
I'm glad you're with us. Did you have any comments?
Sarah, I do. Just as Sarah has been saying, the information that we received from CMS about the phased reopening approach, there's a lot of information in there to be digested. Of course, they are urging, you know, collaboration between state leadership, state survey agency, state and local health departments. So it's, you know, we're going to have to kind of all get together and put our heads into it and come up with the best plan that we think, you know, will work in Virginia. I know one of the questions that came up earlier was about if an employee refuses to be tested, and I think Dr. Solano is correct. The plan does speak of the facility having you know, protocols or plans in place to address those types of situations. Another question that came up about testing was if the facility has the Cepheid platform for flu testing, and should they go ahead and look at performing their own testing. And to that, I would just word of caution, the Cepheid flu test is probably a wave test under the CLIA test complexity. And offhand, I don't know what complexity the COVID-19 test is classified at, but just the facility would need to make sure that based on whatever complexity that test is classified, that they have the correct corresponding level of CLIA certification to be able to perform that testing on site.
Okay, great. Do we have any other questions in the chat box for Kim?
No, I don't see any.
I did see a question. Has it been said that we should attempt to do facility-wide testing even if we've had no cases? Is anyone available to respond to that question? And the OLC's opinion on having activities outside?
Yes. Oh, yeah. Activities outside. So there have been questions from different states that have been submitted to CMS with questions related to that. And so they have provided some responses back that I can go back and share and look for the information. I think, I mean, I think we've had some facilities, honestly, who have been engaging in activities like that, you know, already. So I think as long as they're, you know, still adhering to the guidelines, I don't, you know, really see a problem with it. But again, I'll go back and look at some of the responses that we've received.
Okay, great. Well, thank you so much for being on, Kim. We really appreciate it. There was another question that came in as we move over to Sarah with the VDH lessons learned. You may address it, Sarah, and if you don't, I'll just bring it up before you finish your remarks. So over to you.
Sure. I knew we were talking about testing today, so I really don't have any other remarks. I know we're about to run out of time as well.
Okay.
But I'm happy to answer any additional questions.
Okay. Well, over to you, Melissa, for the chat box.
The only other question, okay, so 2 questions have come in. Will there be funding available to conduct the weekly tests that CMS is requesting of staff? We would need to have additional nursing hours to be able to complete that for all staff each week.
Yeah, I think that's a great question. We are pulling together our leadership to talk about the funding piece, so I don't have an answer, but certainly I think that's a big question that the CMS memo brings up, and definitely appreciate the need to have additional nursing hours to complete testing. We understand that testing takes a lot of time and effort, and that's why we've been using the National Guard for support to do that. It's not just doing the testing, but all the data entry and paperwork that has to go along with the collection of all the swabs. So we'll certainly think through that as we think through the funding piece.
Great, thank you. And Jody, I know we're going to go to you, so we already have a question for you. So I'm going to go ahead and ask it in advance, which is one CMS memo says no group activities. So that's what we were concerned about. If we did them outside, want to ensure we would still be compliant. So Jody, that's the question for you.
Yeah, and it's interesting that the group, the outside activities comes up, because this is something that we were asked by CMS about reopening guidance, and the group activity, or I'm sorry, outdoor activities and even outdoor visitation was something that we had recommended to CMS that obviously did not make it into the into their guidelines. So they have not said that you can't do that, but based on the fact that we did recommend it and they chose not to include it, I think that it seems that they may not be in support of outdoor activity and outdoor visitation, at least not ahead of when those things would be permitted with the CMS guidance. So if I hear anything differently, I'll definitely let you guys know, but I will launch into that guidance right now. And so I was going to talk about the Nhsn reporting and the guidelines today for reopening. In the interest of time, should I only do the reopening or should I still do both?
If there's any way you could do both, that would be great.
Okay, yeah, great, no problem.
Thank you.
So I'll start off with the reporting. Your first deadline to submit your Nhsn reporting to CDC was this past Sunday, May 17th at 11:59 p.m. And we checked in with CDC on Monday morning just to say, you know, how did everything go? Is there anything that we can share with members? Because we've been trying to work with them to see any problem solving, troubleshooting things that we can do. And they said, as of yesterday morning, there were about 14,500 nursing homes either enrolled or pending enrollment. There's, you know, 15,500 in the country. So we didn't get all the way there, but we did get a lot of the way. Only 10,779 had reported as of yesterday morning. We know that there are continuing issues, and we brought these up with CDC on a call last week and then followed up twice with both CDC and CMS on these issues. So there continues to be a seemingly bottleneck at the step of registration or enrollment that is your SAMS verification, your identity verification. I reached back out to CDC just this morning to ask if there had been any updates on that. When we talked last week, they said that they were going to look into that issue. They were investigating, but they were aware of it. A second issue that we seem to find or be hearing a lot from members is a last step. And so once you complete your SAMS, you receive an email that says, congratulations, you've been enrolled. You're supposed to then receive a separate email that prompts you to accept an agreement to participate in consent. We talked with CDC last Wednesday, and they had just discovered about an hour before our phone call that that email was not being automatically pushed out. So they were working on some different things, a few workarounds to try and address that issue, but we are aware that that's still a problem. We have made them aware of that and made CMS aware that that's still an issue. And then we also know, of course, that there is a huge delay in processing emails that go to that user support email, the nhsn@cdc.gov. So we are trying to, as I say, problem solve with CDC on those things. They have been very responsive to us, and I'm grateful for that. I know that they're working very, very hard. I also know how stressful this is for you all and how frustrating it is, because as we impressed upon both CDC and CMS, it's not just about this looming fear of the enforcement actions that would take place at the end of the month and on June 7th if you had still not been able to report by those dates. It's the fact that we want to do what we're supposed to do, right? Reporting is going to be helpful for combating this virus. And we are, nursing homes who are trying to meet requirements. We're trying to do what we're supposed to do. And it's not just because we don't want to get in trouble. It's because it's the right thing to do. So we have impressed that upon both groups. We're also advocating to CMS that they don't overlook this group of folks who, according to CDC numbers, are actually enrolled, but because of whatever glitches are in the system, maybe they haven't gotten that agreement to participate in consent, or for whatever reason, they're not able to report. We feel like that's a really, really important number that CMS needs to be aware of, because we don't want anyone drawing conclusions that people are enrolled and just aren't reporting just for the, for the fun of it. So I will keep you guys updated as that goes along, but we are working very hard with both CDC and CMS on that reporting. Now, on to those new CMS recommendations. They issued recommendations for reopening of nursing homes on May 18th, and they also issued a frequently asked questions document. And I think that Dana had posted both of those links in the chat box today. What's interesting about these recommendations is that even though they came out in a QSO memo, and usually when things come out in a QSO memo, it means act on this immediately or you're going to be in big trouble. These guidelines are actually directed at states, and they are guidelines that are to be adopted at the state level, much like the White House's guidelines for opening up America again. And in fact, these guidelines track right alongside the opening up America again phases. For the phase 1 of opening up America again, the White House's guidance, CMS says that nursing homes should still remain at their highest level of vigilance throughout that time period while the surrounding community completes phase 1. There are a number of factors that states need to consider in adopting these guidelines and implementing the reopening of nursing homes. These factors include your community case status, the nursing home's case status, staffing, testing, PPE, universal source control measures, which include everyone wearing masks and social distancing. And they also need to be considering local hospital capacity should there be another surge. States have an option to choose that all nursing homes move through the phases of reopening nursing homes together. They may choose that the nursing homes move through by region. So one example that CMS provided was like a county by county situation, or the state could choose that the nursing homes would move through these phases individually. But what's interesting to note is that regardless of what phase or, what method your state would choose, at any point in time, if a nursing home experiences a COVID-19 positive case, that nursing home goes back to the highest level of mitigation and has to start all over again and progressing through the phases. So this is a really complicated, very complex thing to navigate from the get-go before you add in all these other factors. A few other things to keep in mind before a nursing home can even think about reopening is this strategy for testing that we have been talking about on this call all day. CMS says that there needs to be an initial baseline test for all residents and for all staff, and then staff need to be tested on a weekly basis thereafter, and residents would be tested anytime an individual presents with symptoms that are consistent with COVID-19, or if a staff member tests positive. In that case, all residents would be retested and would continue to be retested on a weekly basis until all residents test negative. And there's a lot that goes into that that I'll kind of unpack at the end of this, but it is going to be challenging. We recognize that for a number of reasons, and we are advocating with CMS on that. Additionally, CMS says that a state should survey any facility that has a significant outbreak. They haven't defined what a significant outbreak is. We will find out if that is to be determined by the state and what parameters the state would use to determine that. Now, it's important to note also this framework doesn't really throw open the doors. A lot of the restrictions that are currently in place will remain in place even as the nursing home moves through all 3 phases and completes the 3rd phase, or maintains in the 3rd phase. And those measures would be the universal source control. Everyone is going to be wearing masks in the facility for indefinitely. Everyone's going to be social distancing even once visitation resumes, even once group activities and communal dining resume. Everyone will continue to be screened, staff and residents. Nursing homes will continue cohorting residents with those who are COVID positive, those whose COVID status is unknown, maybe they're a new admission or a readmission, those who develop symptoms but haven't yet been confirmed as COVID positive. Nursing homes will continue to limit non-medically necessary outside appointments throughout all of the phases, and infection control surveys seem to be here to stay, at least for a little while. So keeping all of that in mind as your baseline, here's the things that are going to change through this phased reopening. We are currently in what's called current state highest mitigation or significant mitigation, and you will remain in that state as the community around you goes through phase 1 of the White House's guidance, as I mentioned earlier. Once your surrounding community enters phase 2, at that point, and maintains no rebounding cases throughout phase 1, then if your state approves, and however they approve it, you could enter phase 2, where you would be allowed to permit limited entry of non-essential personnel. And of course, they would be screened and they would need to be wearing appropriate PPE, at the very least a cloth face covering. You would be able to have limited group activities or outings, which is a huge deal, but these need to be limited to 10 people or fewer. They are only for residents who are asymptomatic or COVID negative, and then of course everyone would continue to wear masks. They would need to social distance. In terms of survey, your complaints and facility reported incidents would now include investigations for allegations with actual harm. So remember that our current state had been that only immediate jeopardy and only infection control surveys were taking place. So now with this phase 2, they're going to add in the actual harm, and they would be prioritized as follows. Abuse and neglect would be first, infection control next, but that includes failure to notify families, that new requirement, failure to notify families, residents, and representatives about COVID-19 status and information. Next would come a violation of transfer and discharge rights, insufficient staffing or competency, and then any other quality of care issues like pressure ulcers or falls. Once you get to phase 3, visitation is permitted, but of course, social distancing, masks, hand hygiene, screening for all visitors. Non-essential personnel are now permitted beyond just that limited non-essential personnel, and that can include volunteers. Group activities and outings are further expanded, but what they say around this is that if you can safely accommodate more than 10 people, meaning that you can still socially distance with more than 10 people, then you can go ahead and have more than 10. If you can't socially distance safely with more than 10 people, then you are restricted to how many people you can safely socially distance. Normal survey activity resumes, and there's prioritization for this as well. Facilities with a significant number of positive cases come first, then special focus facilities, then special focus facility candidates, and then those who are overdue for their standard survey and have a history of G-level noncompliance in those issues that I named above: the abuse and neglect, infection control, transfer discharge, quality of care. The things that we're picking up about this, and it's a lot of information, it's very dense and as I mentioned, very complicated. There's no guidance for what comes after phase 3. So we don't know how long we're going to be in phase 3. Is this our new normal? How long are we going to be screening? How long are we going to be doing this weekly testing? How long are we going to be wearing masks in the facility? How long will we be practicing social distancing? A lot of those questions still remain, and we just don't have answers for them. It's probably going to be largely dependent on what happens with COVID-19 across the country. We are advocating at LeadingAge for federal support among a number of issues. So first and foremost, we have to have support for testing. We've got to have support for those testing supplies, and we've got to have support for PPE. We didn't have enough PPE when this started, and it's not getting any better. We're hearing about those FEMA shipments that are going out. They are not including N95 respirators. In some cases, they're not even including surgical masks. And so we really need support from the federal infrastructure if number one, we're going to get past this virus, and number two, if we're going to be able to do any reopening in a safe way. So we're working on all of those things. We'll keep you updated as things progress.
Thanks, Jody. To clarify, we're currently in phase 1. So it does say we can have some activities with social distancing, hand hygiene, and use of a cloth face covering, but the phase 1 doesn't mention the 10 people limit, but phase 2 does. So
yeah, CMS is a little tricky about that because it also talks a little bit about the communal dining, and that's something that we had asked them about because our understanding, of course, was no group activities, no communal dining, all of that. As we are reading it, you can't be doing your group activities like your large group activities or your group dining, but having 2 or 3 residents together who are socially distanced and practicing all of the other universal source control measures. It seems that CMS is not having an issue with that. They did even address the dining part of it in one of their FAQs that was recently released.
And then, Jody, I'm sorry if you already touched on this, it's so complex, but if you have a resident who was positive prior to May 1st and a retest was done and that result is positive, do we have to report to CDC as new positive since it wasn't reported in the system prior, or would this not be considered new since it is not a new resident infection?
That is a really good question that I don't actually have. I don't have the information for that. I would need to check with CMS and check with CDC and look back over the CDC guidelines. If you'd like to email me, of course, anyone's welcome to email me at any time, but if you would like to email me on this specific question and I can get back to you on what I find, my email is my first initial and last name, JEYIGOR@leadingage.org, and I'd be happy to look into that more.
Yeah, and Jody, I'll follow up with you on that, and then we can get that out to everybody.
Sounds good. Thank you.
And then one last question. After reporting, is there a step missing from notification that the reporting was received?
So my understanding is that you will not receive any type of email notification or anything like that. You are to log back into the Nhsn system and you'll be able to see there, I think it's a calendar that pops up and you can see on that calendar and check there that you're reported. And I think it's a really good idea to do that. Particularly, we're hearing of states where the state health department is reporting on behalf of nursing homes, or the QIO is reporting on behalf of nursing homes, which is great. We really appreciate that everyone's pulling together. But remember that CMS is going to hold the nursing home itself accountable. Every Monday, starting May 31st, they're going to be pulling the data using your CMS certification number, your CCN. And so when they pull those numbers, if there's nothing showing up for your facility, they're not probably going to take the time to look at it and go, oh, I wonder who is supposed to report that. Is that the QIO's fault? Is that the state's fault? Is that the nursing home's fault? So I urge every single member to go back in and double check, even if someone else is submitting your data for you.
Well, if we don't have any more questions, I really want to thank everybody for hanging on. I know we went over a little, but it was a lot of great discussion. So thank you, Jody. Thank you for everyone. Our next call will be May 27th at 11 a.m. Just know we're here for you. If you have any questions, please send those to me or Melissa. Thank you so much and have a great week, everyone.